To begin, I'd like to thank everybody for joining us on behalf of the Multiple Sclerosis Foundation. We are delighted to have this opportunity to come together with all of you and discuss this really important topic. I am your host, Casey Minnis. I'm Director of Communications for MS Focus, and I'm joined by Tirisham Gyang, who will be talking to us about COVID-19 and MS. This will be a town hall format, so we're looking forward to hearing from you. After a presentation from Dr. Gyang, we'll open it up for your questions and comments. And now I'm delighted to introduce our speaker. Dr. Gyang is an assistant clinical professor with the Department of Neurology at the University of Florida College of Medicine. She subspecializes in multiple sclerosis and related neuroimmunological disorders of the brain and spinal cord. Since joining UF, Dr. Gyang has worked with the MS division to build a comprehensive MS clinic. Dr. Gyang serves as the principal investigator in many clinical trials and clinical research projects, while still being actively involved with patient education programs for the MS population. Additionally, she serves as the fellowship director for the MS Clinical Fellowship Program at UF. Dr. Gyang is a National MS Society scholar and an active member of multiple professional societies. We're very pleased to have her join us to present this important topic. So, Dr. Gyang, I'll turn it over for you and also ask that you give us a little introduction of Carlos as well.
Sure. Well, thank you, Casey, and thank you to the MS Foundation for organizing this event. Before we started, I said, we usually do these in a hotel where we invite people to come over and we have a meal. But due to COVID, we decided to do it on Zoom. And I mean, it kind of in the beginning was, a bad thing that we couldn't be in the hotel together. But I just realized that we have so many people from all over the U.S., and I think it's excellent that we can all connect and we can all talk about, the experiences we have and what we're going through. So as Casey said, I'm with the University of Florida. I have a few slides, but I want to leave a lot of time for questions because I think, sometimes, we don't know what questions people have. And, I don't want to just tell you, what I have prepared. I really want to hear from everyone that, has a question. And with me, I have one of our MS fellows. He is he has one more month to graduate. So he's, almost a fully certified MS doctor. It's Dr. Carlos Sollero, and he has been with us for about 2 years. We're going to do the presentation together. I'm going to start, and then he's going to do a few slides towards the end. I'm just going to start, and I have not a lot of slides, but I'll try to talk through. And if there are any questions, please just write them down, and we can answer any questions that come up, after the presentation. I just want to say that, there's still a lot of things we do not know about the coronavirus and how it affects patients with MS. So I can't promise that I have an answer to every question, but I want you to ask whatever questions you have, and we'll try as much as we can. All right, so I'm sure, I think almost everybody in the world has heard about this. The issue became a pandemic sometime in March. So what actually is COVID-19? And COVID stands for coronavirus disease. The 19 stands for 2019 because that's when it started. It's caused by a virus. The long name of the virus is severe acute respiratory syndrome virus 2. So it's always abbreviated as SARS-CoV-2. That's the name of the virus. Now, there are other types of coronavirus that are out there, but this is the first time this specific strain of the virus has infected human beings. And so, coronavirus in general is not a new thing, but this specific type of coronavirus that's very unique has never been seen in the human population until now. And that's why it's called a new virus. From what we understand, it was initially identified in Wuhan, China, in December of 2019. From all that we believe at this point, it's most likely a transmission from an animal to a human being. And why do we think that? Well, when we look at coronavirus that infects animals, this specific virus, looks very similar to the coronavirus that we find in bats and in another animal called the pangolin. So this specific strain of the coronavirus that has never been seen in the human population, very similar to this virus, has been isolated in animals like bats and pangolin. So it's thought that this is most likely a transmission that crossed from an animal to a human being. And then subsequently, there was human to human transmission. So one human being then could transmit it to the other person. And, this started in December in China. And then by March, it's a pandemic. So it has spread so much all over the world that, I think at this point, probably almost every country has either a case or is prepared and is taking precautions against the coronavirus. Go to the next slide. And so how is this virus transmitted? So it's, from what we understand, it's transmitted by small droplets. So whenever we breathe or we're talking or we're sneezing, we discharge, in addition to air, very small droplets. And so if the virus infects the nose, the mouth, the virus can remain in these droplets, and whenever we sneeze or we cough, the virus is disseminated out of the person that's infected with the virus. Once it has been discharged from one person, if it gets into another person and it gets in through these droplets, so let's say another person comes in contact with a droplet from the person that has the virus, and it happens to get in the eyes or in the nose, this virus can get into, the mucous membranes, into the system of this new person that has become infected, and the virus starts to divide and replicate in the new host. Now, what's the incubation period? And when we say the incubation period, it means what's the time between your first exposure, meaning the first time you had this droplet, let's say from a surface or somebody coughing or sneezing and somehow getting into your mouth or your eyes, what's the time between that and the first time you have symptoms? That's what the incubation period refers to. The incubation period is anywhere between 2 to 14 days. So after you're exposed, it could be a few days or even up to 2 weeks before you show the first symptom, because the virus needs a lot of time to replicate and to divide. And so this becomes a big issue, because even though you don't have symptoms in the first 2 weeks, you can potentially spread the virus to other people. When you cough, when you sneeze, when there's all these droplets coming out from that person that still doesn't have symptoms, that virus can be transmitted to other people. And so this is just an example of, we can use this technology to show us how droplets are emerging from a person that's sneezing. So, and this is a normal sneeze. I mean, if you're looking at a person sneezing, you don't see all these droplets. But this is actually what is coming out when you sneeze, and when anyone sneezes and your mouth is not covered. There are hundreds and maybe even thousands of these little droplets that you can't see that come out of you. And so these droplets in a patient that's infected potentially have the coronavirus. And any of these droplets, if let's say, it gets on another person or it gets on a surface and another person touches that surface and ends up with their mouth, their hand in the face or close to their eyes, that transmission can happen. And so what are the symptoms of coronavirus? So we kind of have gone through the time where the person is exposed, there's an incubation period. So the common symptoms are listed on the left. And we have most people present with a fever at some point, almost 99%, so 83 to 99% have a fever. And then think about all the symptoms of the flu. So loss of appetite, fatigue. One thing that's unique to this coronavirus is that there's a loss of smell in people, and not in everyone, but a lot of people complain of a loss of smell. And there are people that, have been very minimally symptomatic, but then have lost their smell, for the time period of which they're infected due to this virus. Another big symptom is shortness of breath or difficulty breathing, because the coronavirus can, as it infects the airway, can get into the air system, into the lungs. And at that point, patients can start to have difficulty breathing. Cough is another common symptom. And so a lot of times it's a productive cough, or, a third of the time it's a productive cough where you're coughing off something. Aches, pains, just like, people have when they have the flu. And then you have on the other side, severe symptoms. Now, most people are going to remain here. Common symptoms, right? Most people are going to remain here. Some people are going to have more severe symptoms. And what are those severe symptoms? So there's difficulty walking, confusion, or, being very disoriented, bluish face or lips because they're not breathing adequately. And so people start to turn blue. Sometimes people start to cough up blood because of the damage that this virus is doing in the lungs. Chest pain. A lot of people have complained of chest pain because there's a lot of inflammation in the chest, in the lungs, and that tends to cause a lot of pain. When we look at the blood, many people have a decreased white blood cell count. And this is something that, we see in the hospital, in the clinic, when we're evaluating patients. Kidney failure has also been reported in a lot of people. High fever, and there's a lot of other case reports of, there are patients that have had strokes, or other severe types of organ damage due to the coronavirus. So most people have very minor symptoms. A few people are going to have more severe symptoms. Now we've been able to characterize who is more likely to have more severe symptoms. And I think from what we understand, it's clear that people with other medical conditions, especially cardiovascular disease, so heart disease, any kind of heart issues, or high blood pressure or diabetes, or patients that are older, so anywhere, older than 60, 50, 60 and above, or people that have an underlying medical condition. And there's been a lot of thought about, how about MS? How does the coronavirus affect patients that have MS? Do patients with MS have an increased risk And then the other big thing we think about is a lot of our patients are on medications that suppress the immunity. And so is there a bigger risk for patients with MS, on some of these treatments to, first of all, contacting the virus? And if they contract the virus, do they tend to not do as well as other patients? So these are still questions that I don't think have been adequately answered. We will try to bring you the data that we have so far on what we know about the coronavirus and MS. Now, how do we prevent it? And we're going to come back to, coronavirus and MS, but I want to take one slide to talk about prevention, because that's the most important thing. This picture is from the CDC, which is what we've been encouraging our patients to do, to follow the CDC guidelines. Now, as we said, it's spread by these droplets. And so washing your hands very frequently, because if your hand comes in contact with a droplet and then your hand ends up in the face, eyes or nose or mouth, then that virus can be transmitted. Cleaning surfaces, so your desk, anywhere that you're touching a lot, or the surfaces that we use very often, we want to make sure these places are cleaned multiple times a day. Avoid touching the face, including the eyes, the nose, the mouth, because as we said, the virus can linger, on surfaces. And if you happen to touch one of those surfaces and your hands go in the face, that could be a transmission. And then of recent, the CDC has recommended the use of face masks. Now, there's different types of face masks. There's the regular surgical face mask, or a lot that is being improvised, whether using some kind of a cloth to cover the nose and the mouth. And then there's the professional ones that are used by doctors called the N95 Mask. And that is usually used only by those that are in direct exposure or potential contact with patients that actually have the virus. So the N95 it makes a very strong seal in your face to prevent anything from coming inside. And that prevents the patient from prevents the person wearing the mask from getting the infection. The regular surgical mask, or the ones that you can improvise at home, mainly prevent the person wearing the mask from transmitting the infection in case they have it. And so if you remember the picture of the man that was sneezing, if he had a mask on his face, all those droplets are not going to get all the way out. They're going to be shielded by the mask. And so those are the recommendations at this point about wearing a mask. And then the other big things, which, we've all been impacted by, are social distancing. And so we want people to avoid crowded areas, avoid unnecessary travel where, a lot of people are in the same place, like in an airplane or in a bus where, there's many people in one place. As of now, there is no vaccination yet, but there's a lot of work that's going on to try to, produce that vaccination. And once that vaccination is out, hopefully it's something that we can use, in the whole population to prevent further transmission. Because if you have immunity against it, let's say you have those antibodies, you have a vaccination and you produce antibodies against it, the hope or the goal is that even if you become exposed to it, your immune system is going to fight it and take care of it because you've built up that immunity through that vaccination. So there's no vaccination yet. There's a lot of talk about maybe towards the end of the year or early next year, we're going to have a vaccination that's out, but, there's no set date. We're all waiting and expecting that the vaccination would come out soon. All right, so Dr. Sollero is going to have a few slides about MS therapies and COVID-19. And then afterwards, I would just say a few words. And I think he's also going to go through the potential of the risk of MS due to, being on a medication or, not being on a medication based on what we know so far. And as I said, we still don't know a lot. I mean, this all started, less than 6 months ago. So, there's none of this is, solid, hard facts of what we know. There's just a few papers that have been studied in MS patients. And this is what we think so far in terms of giving precautions to all our patients. So I'm going to hand it over to Dr. Sollero to begin talking about MS therapies. Can you unmute yourself? Okay, it looks like he can't unmute himself. Let me see if I can unmute him.
Okay, I think you unmuted me. Okay.
Okay.
All right. So thank you for the introduction. As Dr. Gyang said, my name is Carlos Sollero. I'm a fellow at the University of Florida. And so let me, and I also need, apparently saying that the host has disabled screen sharing for me.
Can you see the screen?
Yes, I can, but I'm not able to share my screen.
Okay, there you go.
Okay, you're just going to...
I can move the slides for you.
Dr. Sollero, I just made you co-host. I'm not sure whether or not that's going to let you advance Dr. Gyang's slides, but we can give it a shot.
I can do this. Here we go.
Should I maybe unshare?
No, it's okay. There, I think I when I did this, I stopped yours, right?
Perfect.
Okay, all right. So as Dr. Gyang said, I'm going to talk a little bit about more specific questions regarding COVID-19 and multiple sclerosis, a little bit more on MS therapies. Okay, so so there are two big answers that we try to answer when we address the multiple sclerosis and COVID. There are two main questions that we need to answer before we make specific recommendations, which is usually what the patients ask us. So should I change something, and should I not change something? What should I do? And these two questions are, firstly, do the MS therapies actually increase the risk of the infection? So if you are in one of the MS drugs, is your risk of acquiring COVID more significant than otherwise? And the other one is, in the case you do get COVID and you are on a multiple sclerosis therapy, what does that mean? Are you more exposed to the serious manifestations of COVID? As Dr. Gyang was mentioning before, the vast majority of patients who have COVID have actually just very mild symptoms, flu-like symptoms, and unfortunately a minority can develop quite severe manifestations in the lungs, but also elsewhere, even neurological manifestations. So the main question becomes, is the fact that you are on one of these MS therapies leave you more prone to these more significant manifestations? And we'll try to address both these issues, even though, as Dr. Gyang also mentioned before, we don't have a precise answer for those. So this is still very early on in the course of this disease, even though the pandemic has advanced quite a bit. But it has been just a couple of months. It's very hard for us to have solid evidence. It's hard to have solid evidence in medicine to begin with. So in this short term, it's very difficult. So pretty much what we have is very well-educated opinions, but they are still opinions, and they can change over time as the facts change. It's a very dynamic situation, and I'm sure you all are very well aware. So, So first, to address both those risks, the risk of acquiring the disease and of having more severe manifestations, two things are important to understand. One is that the risk will be dependent on each medication, because even though they all treat MS, they work in completely different manners. So you have medications that will have zero to none negative effects on your immune system, to medications that are highly immune suppressant. So of course, that's going to affect differently your risk of both getting the disease and how your body will respond to the virus in case you're exposed. The other thing to keep in mind is that the interactions of each drug with the virus are still not well understood, which is what I was kind of touching on before. There's not a lot of hard evidence. All we can do is try to make sense of how these drugs work and make recommendations specifically to each scenario and also to the risk that the disease poses. It's very important to keep in mind that it's always a difficult thing when we're trying to weigh a risk that we are not entirely sure what is, which is this: what's our risk of COVID in one of these medications against a risk but that on the other side of this equation, there's a risk that we know, which is the risk of your multiple sclerosis. So say if you have highly active disease, a very aggressive disease, you've been having relapses over the past few months, the risk of taking off medication is significantly higher than taking off medication in a patient that's been where the multiple sclerosis has been quiet for a number of years and no relapses, even on a lower efficacy medication. So that would change significantly. But I'll try to be a little bit more specific. I know I've been talking in very broad terms. So I'll try to be a little bit more specific and talk a little bit about each medication. So this is a big table. There's a lot going on here. But I'll try to touch, these are some of the most common drugs that we use to treat multiple sclerosis. So I'll try to make brief comments about what it means to our immune system and what the risk, both of contracting the disease, and then I can make a little comment also on the risk of serious manifestations of disease depending on each drug. So starting here, the top two drugs on this list are the injectables. And as you're probably very well aware, these are typically regarded as the safest drugs that we have to treat multiple sclerosis. And this principle will probably also be well extrapolated to COVID. They are not immune suppressing, so both interferons, there's a multitude of them. So the commercial names would be Avonex, Betacilin, Rebif, Plegridy. These are probably the names that you guys are more used to. And glatiramer acetate, which is Copaxone. They're not immune suppressants. And they likely will not increase the risk of you acquiring this virus. And in the case you do acquire it, there's actually people looking into interference as a possible therapeutic uses of the interference with COVID. It is known that some of the interference have antiviral effects, so it's something that's actually being studied. So if you're on interference, it doesn't really make sense to change what the therapies that we have been doing, or Copaxone for that matter, to change therapies based on the current situation. The next series of drugs, which include teriflunomide, which is Aubagio, dimethyl fumarate, which is Tecfidera, and eculizumab, which is Tysabri, they are what was branded here as. I see there is a couple of questions regarding these medications in specific, and I'll try to touch on them as I go. Again, the ones that has been branded low risk, and just another comment, this table is adapted from two recent articles that came out in a couple of different medical journals, both very good medical journals, but they are arbitrary. So they are based on our understanding of how these drugs work. In some cases, this is very incomplete, like teriflunomide and dimethyl fumarate, and even the degree of immune suppression. We're not, for instance, in teriflunomide, which is Aubagio, we're not really, there's no clear indication that this drug lowers the immune system, but that's still a possibility. And in the case of Tecfidera, which is dimethyl fumarate, in normal circumstances, when everything's going okay, and it's the majority of cases, most patients are not immune suppressed, but sometimes when you're on this medication, your white blood cells can actually drop down pretty significantly. And in that case, you would be immune suppressed, and then, of course, your risk would change. So that's just a long comment to say take that risk classification with a grain of salt. But again, what has been considered low risk would be basically Aubagio, Tecfidera, and Tysabri. The reason being, again, because based on our understanding of these drugs, neither Aubagio or Tecfidera, teriflunomide and dimethyl fumarate, should have high, significant effects on your immune system, with the exception, of course, of if your white blood cells go down on Tecfidera, then you probably would have a degree of immune suppression going on. And Tysabri, which is natalizumab, because of the way it acts, it's a highly targeted medication. So it typically it changes the way the immune system behaves pretty much exclusively on the brain, around the brain. So it's a very targeted medication regarding multiple sclerosis. And it can, because of this effect around the brain, it can increase, of course, the risk of infections for a couple of brain infections. But there is good rationale to believe that it shouldn't increase risk for a respiratory virus, even though, again, COVID is a systemic virus, affects all systems in the body, but the majority of the disease that we see is in the lungs. So there's good rationale to believe that Tysabri shouldn't affect that risk dramatically. Going down on the list, we have a couple of the medications that are called S1P inhibitors, which is fingolimod, which is the probably more familiar, which is Gilenya, and siponimod, which is the newer Mayzent. These are kind of sister drugs. They work very similarly, and they do cause some degree of immune suppression. They lower the way they are designed. They're designed. Sorry, are you guys getting some background noise? Let me try. Hopefully this will improve a little bit. Okay. So these, as I was saying, fingolimod and siponimod, both are designed to reduce your circulating white blood cells, so there will be a degree of immune suppression. They're not potent immune suppressants, but certainly some degree of immune suppression is possible. And it is reasonable that these drugs could increase the risk of you contracting this infection, as there are other viruses that we know can become active more frequently in patients with these drugs. Something somewhat similar is also probably the case on the anti-CD20 monoclonal antibodies. So these are the infusions that you get once every 6 months, either ocrelizumab, which is Ocrevus, or rituximab, which is Rituxan. They work very similarly. And again, both of them will likely, they change the way your immune system behaves. And we know that they can increase your risk of contracting a bunch of viral infections. So it is possible that they will increase the risk of you contracting COVID. But on the other hand, it's also possible that these medications may have a protective effect if you do contract the disease. And what do I mean by that? So it's possible that at the same time, this medication may make it easier for you to get the virus, but may make the risk of that second question, your risk of developing serious manifestations of the disease, may go down. And again, this is not something that we know for sure, but it's something that's being studied because it makes good sense based on how the inflammatory response in the lungs work to the virus, and being that the inflammatory response to the virus is actually causes more trouble than the virus itself. Let me just see something going on. There's a lot of. Okay, I'm sorry. There's a lot of questions going on in the chat. I'll try to address them towards the end. I'll just keep going here. And of course, and down there on the list, these are drugs that were called either one of these series of communications that have been across neurological journals. And again, this has been an American group, there has been a British group, an Italian group, a Spanish group, and they're all pretty similar in their recommendations. So these are the ones that are considered of highest risk. And it would be cladribine, which is Mavenclad, alemtuzumab, which is Lemtrada, mitoxantrone, which is Milvantrone, and is very rarely used currently, at least here in Florida, we don't use it very often, and stem cell transplant. So these are more, and the reason they are listed as high risk is because all these options are broad immune suppressants. So they will suppress your immune system in multiple fronts, and they are known to increase the risk of several infections. So there's good rationale to believe that they would also increase the risk of you developing the virus, the COVID virus, and due to them being broadly immune suppressants, it may hinder the way that your immune system deals with the virus. So the rationale behind them is not that exciting as something to control the infection, and more something that you would be at risk. So let me see. I got stuck here. So after going through all this, again, there's a lot we need to take into consideration if you're trying to make a decision based on one specific patient. What I think, and of course, there's, as I mentioned before, there's no universal recommendations as of yet. There's a need to individualize the approach. As I mentioned before, it really depends not only the medication you're on, but also the type of disease you have and which demographic you belong to. So if you are a 20-year-old that is on a medication with low risk, it's a very different question than if you're over 70 and you're on a high-risk medication. It's also a different question if you're talking about a patient who hasn't had a relapse, so the MS has been quiet for many, many years, against a patient that's been having frequent relapses in the last few months. So there's a lot of risks and benefits that we need to weigh when trying to make these decisions. And it's a complex decision that needs to be made along your neurologist. It's important to try to understand the best you can the risks on both sides, and then try to get to an informed decision. What I would say that I think most neurologists would agree is that these that are listed as high risk, some of them are induction therapies. Actually, all of them are induction therapies. So it's something you do for a limited time, and either you repeat them or not, but it's not something that you sustain long term. So it might not be the best time to start them. If you're going into these medications and you haven't started yet, delaying it might be wise. And if you're already on it, of course, there are things that you can't go undo, like stem cell transplant, but it may be reasonable to talk about delaying the next dose of cladribine if you're on that stage or you're about to get your next cycle. The same thing for Lemtrada. But again, it's very hard to make a universal recommendation. And these need to be individualized based on your disease and based on which specific medication you're on. Lastly, I would, before I try to address me and Dr. Yang try to address the individual questions. The last thing I would say, if you do get coronavirus, if you get flu-like symptoms, and you're tested, a lot of patients, we've had a couple patients that called us trying to and wanted to help or participate in some way with research. They know that the fact that they're on these medications make from their clinical information very rich and something that we need to collect. So there is a database going on called COVID-MS that's being spearheaded by the National MS Society, the CMSC, and the the MS Society of Canada. So talk to a neurologist if you do get a diagnosis of COVID. Talk to a neurologist to see if you can be enrolled in the database. And it's just, you don't need to do anything special to just collect their information so you can better understand how these drugs and this disease affect COVID. And then, maybe hopefully we can get better answers for these types of questions. Okay. So those are pretty much the slides I had. And I'm sure you guys had a bunch of questions. The chat thing here kept popping up. Mm-hmm. So we'll try to go about them.
Thank you, Dr. Sollero.
Yes, thank you. Thank you both. I'd like to point out to our participants that you can raise your hand to ask a question. If you touch your screen or click on your screen, there's a button that says More. And when you click the More button, you'll have an option to raise your hand. When you raise your hand, I'll bring you on the line so that you can ask your question. While we wait for people to get the opportunity to do that, let me ask you both a question. Several people emailed me in advance of the conference and asked the question, if you are not on MS therapies but have MS, is that protective? Are you better off because of the fact that your immune system is overactive, or are you more susceptible because your immune system is out of control?
I don't know that we have a clear answer to that. What I would say is your risk is probably similar to someone in the community that is not on a immune suppressive drug, but I don't know that we have evidence that MS by itself is protective or increases the risk of getting the coronavirus.
Okay. Now we have a question from Ginger. Ginger, go ahead with your question.
Hi, Dr. Gyang. She's my doctor.
Hi.
Hi. How long are you immunosuppressed with Ocrevus? Is it the whole 6 months, or do you have any idea?
That's a good question. So, as we said, Ocrevus is in the moderate risk category. Mm-hmm. Now, it's a medication that's done twice a year, and it suppresses the B cells. The B cells are in the immune cell profile. Most of the time, it suppresses the immunity for longer than 6 months. So in general, it's dosed every 6 months because in the trials, or when it was first in the development process, they realized that, maybe, on average, people tend to start repopulating the B cells maybe at the 6 month mark or a little bit longer. Now, we don't want to risk that repopulation coming up and then people having relapses.
Right.
So most of the time, it lasts more than 6 months. I've had patients that maybe we stopped the treatment and we kept following the B cells, and even a year out, the B cells were still suppressed.
Okay.
And so in general, people on Ocrevus, we're telling them it doesn't make a big difference if you stop or you take your infusion now.
Right.
Because your B cells are suppressed. They're probably going to be suppressed throughout this pandemic. Mm-hmm. And so, it doesn't make a big difference whether you take that infusion or I have patients that feel uncomfortable going to the infusion center, and I just tell them, okay, let's wait a month. After a month, maybe, things would be a little bit better and you'd be more comfortable going out to the infusion center. Mm-hmm. Because from what we know, it probably lasts more than 6 months.
Okay.
Good.
Thank you.
You're welcome.
Thank you for your question, Ginger. All right. We have several questions in the chat, again, about Ocrevus. Whether you're recommending that people should stay on Ocrevus or go off Ocrevus or push back their infusions.
So that's another good question. As I just said, it suppresses the B cells for probably much longer than 6 months, especially if you've been on it for quite a while. And so, if you have, let's say you have your infusion due this month, your B cells are probably going to be suppressed much longer than that. So taking the infusion now doesn't increase your risk significantly because your B cells are already suppressed for many months, even after this point. So we're just recommending that patients keep on with those treatments, whether it's Ocrevus or rituximab. However, I have patients that their main concern is going out of their house or going to an infusion center where there are potentially sick people there. There are some companies that are doing the infusion at home. And there's some people that I said, okay, let's wait a month and let's just move the appointment to next month, and let's do the infusion next month, because we're hoping that maybe the numbers of coronavirus are coming down. There's not a huge concern about exposure. But in general, we're asking people just keep doing the treatments as is, because over a short time, it doesn't make a big difference.
Thank you for that. Now we have a question from David. David, go ahead.
Can you hear me?
We can hear you.
Okay. I actually have two questions. One is the vaccine that is being developed. Do we know whether it's being developed using the Lyme virus?
Good question. Do you want me to answer that, or do you want to ask both of them?
Okay. The second question is, a person that has MS using Tecfidera, would it be safe for them to take the vaccine?
Very, very good questions. So in general, in patients that have MS, we tend to recommend avoiding live vaccines. And those are like the chicken pox or the shingles. The flu vaccine is okay. The flu shot is okay, but we usually tell people avoid live vaccines. And that's because, number one, if you're immune suppressed and you get the flu vaccine, a live vaccine, your immune status is not intact, and there may be a potential risk for that virus reactivating. And the other potential is in MS patients, whenever we give a very strong immunogenic antigen, whenever the immune system wakes up really heavily, there's a higher risk for a relapse, right? So those are the two reasons we typically want people to avoid live vaccines. Now, we do not know currently if the corona vaccine is going to be a live vaccine. From what it looks like, there's multiple different places that are working on a vaccine. I know in the US, there's multiple, vaccines that are being looked at. In the UK, there's people working on it. In different parts of the world, people are working on a vaccine. Now, until we have a product, I don't know that we know exactly what that vaccine is or what it constitutes. So, good question. We don't know. Once it comes out, or once we have an FDA approved vaccine, we will get all that information, and we'll get, all the details of whether it's a live vaccine or an attenuated vaccine. The second question about Tecfidera. So if a patient is on Tecfidera, the question is, should they take the vaccine? Could you repeat the question? Okay.
Yes, that was the question.
That's good. So as I said, if we have to know what the vaccine is, right? If it's an attenuated or it's not a live vaccine, I think we don't have any issues. I think it's going to be universal. Go ahead and take it. And even if it is a live vaccine, I think when we weigh the risks and the benefits, I feel like maybe there may be more benefit in just taking the vaccine anyway, but we don't know. I don't want to say something that, kind of plays out completely differently, because we always weigh risks and benefits. And, if you have a risk of getting the coronavirus, if you have MS and you have other comorbidities, the risk is significant. I mean, people get seriously ill, if you have certain comorbidities, and, certain proportion of patients die. And we have to weigh that risk against the risk of potentially something happening to you because you took a live vaccine, which a lot of the times is not that high. So I think it's a risk-benefit assessment. Once that vaccine is out, I'm sure we're going to get a lot of information about, what type of vaccine it is, how safe it is to use it. Now, I would say some MS medications like Ocrevus and rituximab may reduce your response to a vaccine, because the B cells kind of funnel into another type of cells that produces antibodies that respond to a vaccination. And so in general, even outside the coronavirus, we always tell patients, once you're on a medication like Ocrevus or rituximab, you may not mount as strong as a response to a vaccination than someone that's not on a medication like that. So I'm hoping that when we have a virus, the FDA is going to give us all the guidelines on how to use it and also give us guidelines on how to use it on patients that are on specific immune suppressive therapies. But until we have it, we can't really say much about it.
Thank you.
You're welcome.
All right. Thank you for your question, David. I'd like to remind folks, if you would like to ask your question live, you can.
I think there's a lot on the chat that I'm looking at.
Yeah. If folks would like to ask their question live, they can hit the More button. You touch your screen. When the toolbar comes up, hit More, and then hit Raise Hand. But for now, we'll take care of some of these questions on the chat.
Yeah. So there's
going back a bit.
I'm sorry, go ahead.
Going back a bit, there was one that says, so the risk increases if we're on Tecfidera and it's lowered our lymphocyte count. Is that correct?
Could you say that again? I didn't get the question.
So Vanessa asked to verify, does the risk increase if we're on Tecfidera and it has lowered our lymphocyte count?
I see. So Tecfidera can potentially lower the lymphocyte count. Yes. So I would say, and this is not based on any data, theoretically, potentially yes, because we know that when Tecfidera suppresses the lymphocyte count, it's very rare, but we may have a higher risk of something like the brain infection called PML. So theoretically, it's possible that if a medication like Tecfidera suppresses the lymph, and Tecfidera does that not in everybody. Some people get a suppressed lymphocyte count on Tecfidera, some people do not. Theoretically, that's just kind of me giving my opinion because I don't have hard evidence to back this up, that potentially, yes, Tecfidera by itself is kind of in that moderate risk zone, but potentially, meaning low to moderate, but potentially the risk may go up if the lymphocyte counts are low.
Okay. And our next question from chat is from Kay. It says, what about IVIG, Gamunex-C, for secondary progressive MS and COVID-19? Will future IVIG infusions contain the COVID-19 antibodies? Will this be a benefit, or will I still need to get a COVID-19 vaccine? I get IVIG 5 days every 3 months since post-Lemtrada 5 years.
Okay, that's another good question. So IVIG, for people that are not aware of, it's an infusion therapy, and what it is actually we pool immunoglobulins from different people. So when you go to a blood bank donation and you donate your blood, that blood is separated into different parts. You get the red blood cells, you get the platelets, and all of that can be infused. In the plasma, we have what we call the immunoglobulins. The immunoglobulins are those antibodies that all of us are producing all the time that help us to protect against certain infections or certain toxins that come to us. Now, IVIG is used for different types of autoimmune diseases. And there is limited data or some degree of data that it may be potentially beneficial in patients with MS. Now, the first part of the question, what about IVIG for secondary progressive MS and COVID-19? I do not think that we know that there's an increased risk with IVIG for COVID-19, especially if that's in an MS patient. Will future IVIG infusions contain COVID antibodies? Well, that all depends. If the whole community has antibodies against COVID-19 and we're pooling the plasma of different people to produce this IVIG, then potentially there may be some COVID-19 antibodies in it. So it's a potential, but I don't know that we could say it's going to protect you and you don't need to do a vaccination if you do an IVIG infusion, because there's no way to know. I mean, one IVIG infusion could be plasma from hundreds or maybe, just many people. There's no way to know which of those people had, and we don't test the IVIG to figure out, which antibodies are in this IVIG. It's just an infusion. It's formulated at the point that it's given to the patient. So it would not replace a vaccine. I would say you still need to go and get the vaccine, even if you're doing the IVIG infusions, because every infusion is different. What if you get an IVIG with antibodies now? That doesn't guarantee that the next infusion is going to have a lot of IVIG, COVID-19 antibodies. So that's how I would answer that. And as I said, we don't have a lot of evidence. We don't have a lot of data at this point.
Okay. I'd like to ask everybody who is submitting questions in chat. There's a lot of back and forth, so I'm not sure whose questions have been answered and whose haven't. If you have a question that you submitted in chat that you don't feel you've really gotten an answer for, go ahead and resubmit that. But meanwhile, we have a question from Kemmerly. Kemmerly, you're on the line. Go ahead. One second. It seems to be having trouble unmuting you.
Am I there?
There you are.
Okay,
there you
wonderful.
We can hear you.
Well, good. Initially, thank you to both physicians and to you, Ms. Minnis, for putting on this excellent program. Thank you. My question is, in reading the medical journals, at least on this COVID-19, with respect to the unusual neurological symptoms that are arising, it seems that there's a crossover in the blood-brain barrier. As horrible as this virus is, do you think that at least studying the virus is going to bring us somewhat closer to figuring out the blood-brain barrier crossover for MS and potentially coming up with some that, get us closer to a cure, at least for MS?
That's a very good question. So yes, that is correct. There are certain cases have been reported where the virus is actually causing neurologic symptoms. And there are certain cases of encephalitis, like brain inflammation or brain infection. There are cases of strokes because it causes blood clots to be formed. So it's not a common manifestation, but yes, there are neurologic manifestations based on the virus having either inflammation or infection within the brain, or the effects of systemic inflammation on the brain. Now, I'm not aware that there's any study that's looking at how the coronavirus affects the blood-brain barrier to try to kind of look at that in light of MS. I'm not aware, and there may be, I'm not aware of every single trial that's going on. But if there are a lot of studies now, maybe some of that information we get now can help down the road. But I'm not aware exactly of a specific trial that's going on. The good thing, though, with the corona, it doesn't appear to be neurotropic. And neurotropic means there's certain viruses that invade nerves. For instance, there's certain herpes viruses or certain, like the PML virus. They actually they propagate or they regenerate or they grow within your nervous tissue. Doesn't appear that this virus does that, at least from what we understand. It usually affects more your respiratory system. It affects other organs, but it doesn't have a strong predilection to go into your nerves to cause damage in the nerves. And I think that's a good thing, because if it did, then we'll be seeing a lot more neurologic manifestations from an infection. But I think that's a good question, and maybe some of the information or some of the data we learn may help us to address questions about MS in the future.
Thank you.
You're welcome.
Thank you for your question. Okay, well, we are just about at the end of our hour. I would like to thank everybody for your comments and your participation. I would also like to tell you that this is the first of many upcoming Zoom teleconferences. Tomorrow at 1 p.m., we have Dr. Terry Walls talking about dietary approaches to treating MS-related symptoms. On Thursday, we have Adrienne DeBerry talking about the ins and outs of specialty pharmacy, and many more conferences to come. We hope that you will follow the foundation on Facebook, Twitter, Instagram, or check our website to get the times and access information. So our sincere thanks to all of you for joining in, and most especially to Dr. Gyang and Dr. Sollero for this wonderful presentation and information, taking the time to answer all of our questions. We really appreciate you both. Thank you.
Thank you so much for inviting us, and I'll just recommend that everybody stay as safe as you can. Take all those recommendations seriously about washing your hands, wearing a mask, and just protecting yourself in this time.
All right. Well, that's a wrap on this conference. Thank you all again, and we hope to have you join us for future conferences. I'm going to go ahead and end recording of this call. And then I'm going to open up the room for anyone who wants to chat for a few minutes before we close. You're very welcome to.